What's up, future respiratory therapist? What's that black strip for on the end of a suction catheter? I'm going to tell you here in a few minutes. But before that, we're going to do an in-depth suction review. Let's dive in. So when we talk about suctioning, it really comes down to about 4 different elements that you absolutely have to remember. Now, this is the mental approach to suctioning. Of course, there's the hands-on manual dexterity that you have to just get more comfortable with, that comes with time and reps in doing. But today we're just talking about the mental things that you need to keep in mind as you prepare for your finals, and some of you preparing for your TMC, your national board exam coming up here very, very soon. Super exciting time right here as we finish up April and go into May. I'm so excited. If you're going to be graduating soon, I want you to leave me a comment down below. Let me know how many days you have left, and if you have any questions, throw them up there. I'll be sure and get back and answer them to you. Make sure your questions are specific. I get lots of questions where it's like, hey, will you share your notes with me over this? No, I won't, because I really don't have notes. I just have thoughts and ideas and brief presentations, and you're seeing it all here now. So take down good notes and send me specific questions. Let's talk about suctioning. There's 4 things you have to remember about the suctioning process, okay? And it comes down to something like this. I'm going to put suctioning right here in the middle. I say I am. I'm going to put suctioning here, okay? So all of this circle is things you have to remember when it comes to the suctioning procedure. First of all, first and foremost, we are always going to hyperoxygenate our patient. Some words may be using, or some classrooms may say pre-oxygenate our patient. Okay, I think Egan's actually says pre-oxygenate. Some instructors and facilities and therapists say hyperoxygenate. Whatever it is, we're going to do this prior to the procedure ever starting. And we'll talk about why here in just a second, okay? After you pre-oxygenate your patient, you need to remember that suction pressure matters. So you want to be sure you're using the appropriate suction or vacuum pressure range. Now, this breaks down to 3 different patient populations. You have your adults, your pediatrics, and your infants or your neonatals. So here we go. When you're talking about suction pressure for your adult, you have to remember this is 120 to -150 centimeters of water pressure. When you're talking about peds, you're talking about 100 to 120. This is negative. And when neos, you're talking about -80 to -100. These 3 things right here, you have to remember them, because when you're taking an exam or answering a question about suctioning and they tell you this vacuum pressure being used, it's got to register in your mind almost immediately that that pressure is too high or too low. All right, that may be the problem that you need to adjust. So you have to know those ranges: 120 to 150, 100 to 120, 80 to 100. Now, beyond suction pressure, we need to make sure we're using the proper catheter size. So we know that catheters are made in different sizes. And so when it comes to taking a suction catheter and putting it down an artificial airway, then we need to make sure we don't occlude an excessive amount of that airway. We do that by using this formula. You got to know this formula. Now, the rule of thumb stated in Egan's is you want to take your endotracheal tube, multiply it times 2, and then go down to the next even number. Now, you got to understand, French catheters, catheter size is measured in French. So you're going to have a 10 French, a 12 French, a 14 French. So when I say go down to the next even, what I'm saying is if you have an endotracheal tube that is a 7.0, well, 7 times 2 is 14. You're going to go down to the next size, which is the next even number. So if 7 times 2 is 14, then for that endotracheal tube, you would go down to 12. If you're using a 7.5 endotracheal tube, 7.5 times 2 is 15. Now we're going to go down and use a 14. That's the appropriate size suction catheter to use for that size endotracheal tube. Now, I know a lot of you are thinking, well, in the facilities I've been doing clinic at, all I ever really see is only one size to choose from. They use that one size on everybody. That might be true, but remember, when you're taking your MBRC therapist multiple choice exam, and when you're taking your final exams, these exams are rooted in didactic theory. Didactic theory has very specific size suction catheters for each size endotracheal tube. So remember that formula. Multiply the endotracheal tube or the tracheostomy tube times 2, and then go down to the next even number. That'll get you your correct catheter size. After we get the correct catheter size and we're using the correct suction pressure and we've pre-oxygenated our patient, then we have to ask ourselves, what do we need to remember about how long we have to perform this procedure? You've got to know that there's a max time. There's not a minimum time, because the answer to this is really however long it takes to retrieve the secretions or adequately remove the secretions. But that time cannot exceed 15 seconds. Okay? So your max time to suction is 15 seconds. If that does not get the job done, you reassess for the need for further suctioning, then this starts over. Pre-oxygenate. We already using the right suction pressure. We got the right catheter. We're going to suction again. Less than 15 seconds. If they need it again, then you do it again. No attempt should ever last more than 15 seconds. These are the basics that you have to know. I can think of probably 10 to 15 questions to ask just based off of these 4 elements right here. Now, why are these elements important? That's the question. Why do these things matter? So we know how to suction, but why do we have to keep these things in the back of our mind? Well, it looks like this. We know that with suctioning comes hazards and complications. So I'm just going to put complications right here. Okay? So this is complications. So why we do all these things is to prevent or to minimize hazards and complications associated with the suctioning procedure. Now, the first one is we know we can cause hypoxemia. Okay? This is why we hyperoxygenate our patient, because the risk of hypoxemia exists. If we can pre-oxygenate and hyperoxygenate our patient, then we'll diminish or reduce the risk of that hypoxemia happening. Okay? Using too much suction pressure can cause hypoxemia. Using too large of a catheter size can cause hypoxemia. Suctioning for too long can cause hypoxemia. So we pre-oxygenate and we keep all of these things in mind to reduce the risk of hypoxemia. We also know that during suction, I'm going to run out of room, so I'm going to write it like this. We can cause cardiac dysrhythmias. Okay? These are things like bradycardia, tachycardia, PVCs, premature ventricular contractions. Anytime you get any of those that happen during the suctioning procedure, the correct response is to stop suctioning, provide 100% oxygen, and ventilate the patient appropriately without breaking the circuit at all costs. Now, if you have to, then you have to. If you have to take it off to bag a patient, then of course you have to. But the goal is to, we've upset the heart. A lot of times, the tachycardia that you will see is in response to either just agitation and coughing or maybe hypoxemia. So, we understand that this hazard can lead to this hazard. Hence the importance to reduce the risk for hypoxemia. What about bradycardia? Well, we know bradycardia is a vagal response that comes with suctioning. So when you see that, and you see your patient's heart rate go from 90 to 45, you want to stop suctioning, provide oxygen, and provide ventilation. Notify the nurse and a physician so that everybody knows that this happened. Okay. Also with cardiac dysrhythmias, this is not typically, it's not a dysrhythmia. I'll go ahead and put it up here separately. We can get hypo or hypertension. This is in reference to blood pressure. Okay. So a lot of times hyper or hypo tension can respond also as a vagal response, but also with the agitation and the coughing that comes with suctioning. Keep that in mind. Another big one here is atelectasis. When you take a catheter and you go into an artificial airway and you apply negative suction pressure within the airways, you can cause the alveoli to collapse. Hence, the importance by remembering proper suction pressure, proper catheter size, proper suction time. Now, hyperoxygenation or pre-oxygenation, it does nothing to prevent atelectasis. Okay, I want to make that point. Which of the following would be most likely to help prevent atelectasis from happening? It would be these three: time, size, and pressure. Which would be applicable to prevent hypoxemia? All of them. So keep that in mind, okay? Atelectasis goes with these bottom three. Hyperoxygenation does nothing for that. Now, there's other things here. Mucosal trauma. You can cause mucosal trauma. Catheter size is very, very, very important here. Intermittent suctioning, depending on your suction pressure, super important here. You also don't want to go super, super aggressive with how deep you're suctioning. Okay, so you've all been in clinicals and you've probably all seen between therapists and nurses and physicians and everybody else who comes in and suctions, you will see them sometimes just take that catheter and jam it all the way in. Okay, that's not necessarily best practice to help alleviate or to prevent mucosal trauma. Let me give you an illustration here. I have a suction catheter here and I have an endotracheal tube. So what I'm going to do is I'm going to show you when I suction this. If I put this catheter all the way in, this much of the catheter comes out. That's about 10 centimeters. Okay, so your endotracheal tube should be somewhere around 3 to 6 centimeters above the carina. And if you go all the way in with the inline suction catheter, then your suction catheter is 10 centimeters outside of the endotracheal tube. That's going to take you down past the carina and probably into the right main stem. And you're probably going to beat up the carina getting into the right main stem. So what Egan says is minimal depth when suctioning. So some people say lining it up with the numbers right at the end of the tube. If you got to come out a little bit to stimulate a cough, this is what they're talking about with minimal depth suctioning. Okay, so just remember, you don't have to go all the way in because it can cause mucosal trauma. Along with suctioning also is you can get a rise, you can cause an increase in your ICPs. So for your neuro patients, keep this in mind, especially those where we're really working hard to reduce or minimize increases in ICPs. Remember that. Now, typically this will return back to baseline after you stop, oxygenate, and provide ventilation. Just remember ICPs can be affected by it. This may be why you may be requested sometimes not to suction unless absolutely needed if you're taking care of that traumatic brain injury patient where we're concerned about ICP. And then obviously the one hazard and complication that comes along with just about everything we do is infection. This is why using an inline suction catheter has become best practice because this helps keep everything sterile and reduces the introduction of bacteria into the lower respiratory tract. If you don't have an inline suction catheter, then you're going to want to use sterile technique when suctioning to minimize that introduction of those bacteria into the lower respiratory tract. That's suctioning. It takes practice to get good at it. Let me advance this catheter. That right there, that's manual dexterity. That's how to do it, okay? Knowing why every element of it is important is super, super a big deal, okay? Let's just recap here real quick. Pre-oxygenation to prevent hypoxemia. Suction pressure, know these three. You got to remember them. Catheter size, you got to remember the formula. ET tube times 2 or trach tube times 2. Go down to the next even number. That will get you the appropriate catheter size. And don't suction anybody greater than 15 seconds, which doesn't sound like a long time, but if I was to just stare at you for 15 seconds, that's about 4. So you get the picture. 15 seconds when suctioning somebody is a much longer time than it feels. And remember all the complications that come with it and how to respond if they happen. Now, before I shut this down, I want to address something that I get asked a lot about. And it is this. Joe, at the end of the suction catheter, there is a black strip. See that black strip right there? What does that black mark tell us? What is it? What's its point? And where is it supposed to be located when we're not suctioning? Now, you can't see the numbers on this, but trust me, this black strip is located at the 5 centimeter mark. So that means there's 5 centimeters beyond this black strip. The reason this is important is if that black strip is visible in that window right there, see that window? You see the black strip is right there now? Look, the catheter is still into the endotracheal tube. Watch. That catheter, the tip of it is now finishing right there. Now, the reason this is important is because ventilation is coming up through this elbow right here. And what we are doing now is imposing an increased airway resistance on our patient. We don't want to do that. We want to take airway resistance away. And in this situation, if you ever see that black marking in the window right here, it's too far in. Even furthermore, if you see the black strip right there, well, now the tip of the catheter is here, and the ventilator is trying to push gas flow past this increased airway obstruction. It's not a good situation. You don't want to have it, okay? So what you want to do is bring this black strip all the way back. Now it's in this window, but guess what? The tip of the catheter is here, still providing some level of airway resistance to the patient. So what I tell my students is make that black strip disappear into this green zone right here. You shouldn't see it past the green, and you shouldn't see it on the backside of the green either. So you don't want to see it back here either, because what that does sometimes is leads to your PEEP filling up this plastic, protective sleeve here with air, and you'll see this blow up like a balloon. That's why, because this black strip, your catheter is pulled back too far, and your PEEP, your positive end expiratory pressure, is inflating this balloon. Or not balloon, but this sleeve, okay? Now, some of you may be thinking, well, Joe, that's great, but we don't use that suction catheter. Okay, I got another one here for you, just to show you that they're not all that different. This is another suction catheter that I've just really seen come onto the market, and it's kind of cool, and I'll show you why here in just a second. But this is another just inline suction catheter, nothing fancy about it. It looks just like the other one. At least on the surface, it looks just like the other one. I'm going to attach it to my endotracheal tube. Tell me what you notice. See that black strip? It's right there. Now this one is not a strip. This one is more of just a dot. But there's the black strip right there. See it moving at the tip of the endotracheal tube? That's the black strip. Okay? That we saw on the other one. Now, I told you that this one's slightly different because it doesn't go all the way around, but it is still there and it is still noticeable. And guess what? It is also located at the 5 centimeter mark. So these strips serve a purpose. You will train your eye to walk into a room, and before you even get to the patient, to be able to see that black strip in the endotracheal tube and know immediately, wait, I got to get the suction catheter back. See it in the window here. See the black suction, the black point right there? It's right there. You're going to go, wait a second, that's too far. I need to pull it back. Same thing, make it disappear in the white. It'll disappear right in here, okay? Now, what's different about this suction catheter? I'm just going to throw it here real quick. I don't even know who makes it. I don't know the name of it. But we do bronchoscopies a lot at the bedside. More and more, it seems like today than ever before, especially since we have the disposable bronchs. What's interesting about this is typically what we do is we have to disconnect and put on the bronch adapter so that we can perform the bronchoscopy. Well, remember, the fewer times you can disconnect, then the better the outcomes are for your patient. That's proven in research. This catheter is very neat because watch. Boom. Take it off, and I now have an adapter from my bronch that I can suction and perform a bronchoscopy through. When we're done with the bronchoscopy, we just take the suction catheter, reapply it, and we're back on. I thought that was kind of nifty and just thought I'd share it with you guys. No affiliation. Like I said, I don't even know who makes it. So I could probably find out if anybody wants to know. But on the surface level, I don't really know. Okay, here's the deal. Finals are coming up right around the corner. Some of you, a lot of you probably have questions that you need clarification on. I am here to help. If you will send me an email, respiratorycoach@gmail.com, and tell me what finals questions you have, put them in the comments below this video. I will start doing final question answers. Videos where I do as many questions as I can, going through helping you with your finals just to make your life just a little easier. Okay? Because I want every one of you to be successful. I can't wait to see every one of you out working in the field as registered respiratory therapists. It's an exciting time, like I said. May, lots of graduations coming up. Also, tell me where you go to school and when your graduation is. I'd love to join you in your countdown. Okay? Hey, in the meantime, thank you so much for watching this video. Remember, average is easy. Don't be it.